This talk is about mutations responsible for resistance to nucleoside RT inhibitors, most commonly referred to as NRTIs. These are my disclosures. There are 5 NRTIs that are currently being used: the cytosine analogs 3TC and FTC, the adenosine analog tenofovir, the guanosine analog abacavir, and the thymidine analog AZT. Almost all regimens contain one of the 2 cytosine analogs, 3TC and FTC. Occasionally, the abbreviation XTC is used when it is uncertain which of the 2 drugs was used in a population. The second most commonly used NRTI is tenofovir. It has 1-phosphate moiety and is therefore also referred to as a nucleotide. There are 2 tenofovir prodrugs, tenofovir disoproxyl fumarate and tenofovir alafenamide. TFE is typically used as the abbreviation for tenofovir, TDF as the abbreviation for tenofovir disoproxyl fumarate, and TAF as the abbreviation for tenofovir alafenamide. This figure shows part of the 3D structure of the HIV-1 RT enzyme, in which an NRTI, shown in yellow, is approaching the active site. The most common sites of the NRTI resistance mutations are shown in red. Most are situated close to the active site, shown in white, where the incoming nucleoside triphosphate is added to the growing primer strand. The NRTI resistance mutations act by 2 mechanisms. The discriminatory mutations reduce the rate at which NRTIs are added to the growing viral nucleic acid primer. The thymidine analog mutations, or TAMs, make it more likely that a chain-terminating NRTI will be removed from the growing viral nucleic acid primer. These mutations are also called primer unblocking mutations. Although the TAMs are associated with cross-resistance to all NRTIs, they rarely, if ever, are selected by current NRTI combinations. They are primarily observed in patients with histories of ART dating back to the years in which AZT and D4T were frequently used. In this presentation, I will first review the drug resistance mutations selected by the 3 main dual NRTI combinations, including TDF or TAF in combination with 3TC or FTC, abacavir plus 3TC, and AZT plus 3TC. Then I'll review the effect of different drug resistance mutations and drug resistant mutation combinations on susceptibility to TFE, abacavir, and AZT. Finally, I'll review the clinical significance of different drug resistance mutations, specifically how they influence the virological response to different NRTI combinations. These figures show the prevalence of 21 of the most common NRTI resistance mutations in patients receiving TDF-XTC, abacavir 3TC, and AZT 3TC. Sequenced viruses were available from about 5,200 persons receiving TDF-XTC, of whom about 3,200 had at least one NRTI DRM, from 725 persons receiving abacavir 3TC, of whom about 500 had at least one DRM, and from about 5,200 persons receiving AZT 3TC, of whom about 3,800 had a DRM. For each of the 3 dual NRTI combinations, more than 80% of samples with a DRM had M184V or I. As you can see from these figures, M184V is much more common than M184I, which is believed to result from the increased replicative fitness of M184V relative to M184I. Tenofovir XTC and abacavir 3TC select for overlapping profiles, but TDF selects more often for A62V K65R and mutations at position 70, while abacavir 3TC selects more often for L74V and Y115F. About 10% of persons receiving TDF or abacavir also had TAMs. This may represent persons with TDR and possibly persons who received either AZT or D4T in the past that was not recorded in their treatment history. AZT selects almost exclusively for TAMs at positions 41, 67, 70, 210, 215, and 219. The multi-drug resistance DRMs, a double amino acid insertion at position 69, and Q151M are exceedingly rare. Most of these DRMs date back to the time before 3TC and FTC became a standard part of dual NRTI therapy. The range and possible reductions in NRTI susceptibility and their clinical significance depends on the specific NRTI. Greater than 200-fold reductions in 3TC and FTC susceptibility occur with M184VI. Much lower reductions in 3TC and FTC susceptibility of uncertain clinical significance occur with K65R and viruses containing multiple TAMs. For tenofovir and abacavir, reductions in susceptibility rarely exceed 10-fold, but low-level reductions in susceptibility to these NRTIs are clinically significant. Like 3TC and FTC, AZT has a high range in possible fold reductions in susceptibility. However, because AZT is weaker than other NRTIs, low levels of reduced susceptibility, as observed with certain individual TAMs, are clinically significant. This table summarizes the effects of the most common drug resistance mutations on NRTI susceptibility. It is based on PhenoSense assay data in the Stanford HIV drug resistance database. As noted in the previous slide, M184V and I are associated with greater than 200-fold reductions in 3TC and FTC susceptibility. M184V and I reduce abacavir susceptibility by about 3-fold and increase AZT and tenofovir susceptibility by about 2-fold. K65R alone reduces tenofovir susceptibility about 2-fold, but in combination with M184V, the reduction in susceptibility is just 1.3-fold. K70E, a tenofovir-selected mutation, is associated with a minimal effect on susceptibility to each of the NRTIs. L74V and Y115F reduce abacavir susceptibility, particularly when they occur in combination with M184V. The TAMs, particularly those at positions 41, 210, and 215, reduce susceptibility to each of the NRTIs. Their effect on tenofovir and abacavir are clinically significant. Much of what we know about the clinical significance of NRTI drug resistance mutations on tenofovir activity comes from a 2004 publication. This table from the paper summarizes the results from 2 placebo-controlled intensification trials in which tenofovir was added as a single agent to the regimen of treatment-experienced persons who had experienced virological failure on one or more previous NRTI-containing regimens. The table shows that by week 24, the mean reduction in RNA level was 0.59 logs. It was particularly high in patients with M184V and no TAMs, 0.96 logs. It was low among those with 3 or more TAMs, particularly those containing M41L or L210W. These 2 mutations usually occur with T215Y, and in fact T215Y and F were also associated with the minimal virological response to therapy. The figure on the right shows that at a reduction in susceptibility above 3 to 4-fold, there was also a minimal response to tenofovir intensification. Although the results were obtained using the antivirogram, which is no longer available, it does demonstrate that low-level reductions in susceptibility to tenofovir can be clinically significant. There were 6 patients with K65R, and each of them had no virological response to tenofovir intensification. Much of what we know about the clinical significance of NRTI drug resistance mutations on abacavir activity also comes from a 2004 publication. The table summarizes the results of a combined analysis of 5 multi-center trials in which abacavir was added as a single agent to background antiretroviral therapy in treated patients with ongoing virus replication. In the small group of patients with wild-type virus, there was an approximately 1 log viral load reduction measured at week 4. Among 75 patients with M184V, there was an approximately 3/4 of a virus load reduction, while among 14 patients with M184V and 1 thymidine analog mutation, there was a 1 log reduction. However, there was a significantly reduced virological response in those with 3 or more drug resistance mutations. The figure on the right shows how the cutoffs of the PhenoSense assay were developed because a reduction in response was not observed until a reduction in susceptibility of more than 4-fold occurred, and no activity was observed for those with greater than a 6-fold reduction in susceptibility. It should be noted, however, that these data are based on virological response at week 4, while the tenofovir data shown on the previous slide were based on virological response data at week 24. The Nadia trial is a more recent trial that influenced our thinking about the clinical significance of NRTI DRMs, specifically the effect of K65R on a TDF-containing regimen. In this trial, the participants had previously experienced virological failure on an NRTI and NRTI-containing regimen. In a factorial design, they were randomized to either dolutegravir or boosted darunavir, and to either TDF3TC or AZT3TC. At baseline, 85% had an M184VI mutation and 50% had K65R. By week 96, trial participants were significantly more likely to have virological failure if they received AZT compared with TDF, 15% versus 8%. The superiority of TDF was observed in those receiving DRV, a 10% difference, and those receiving DTG, a 4% difference. AZT was not even superior to TDF in those with a baseline K65R mutation, which reduces TDF susceptibility by about 2-fold, but increases AZT susceptibility by about 2-fold. Finally, those receiving AZT were at greater risk of developing dolutegravir resistance mutations. Among the 9 patients with virological failure and emergent INSTI drug resistance mutations on the DTG arms, 6 had received AZT and 3 had received TDF. Moreover, 5 of 6 receiving AZT and 0 of 3 receiving TDF developed high-level dolutegravir resistance. How does TAF compare with TDF? Phase 1 and 2 studies have shown that a 25 milligram dose of TAF achieves higher intracellular tenofovir diphosphate concentrations than 300 milligrams of TDF due to the greater plasma stability of TAF and intracellular conversion of TAF to tenofovir. Monotherapy with 25 milligrams of TAF achieved a 1.46 log 10 reduction in plasma HIV-1 RNA at day 10 compared to 0.97 log reduction in virus for persons receiving 300 milligrams of TDF. However, both TAF and TDF select for K65R in vitro and exhibit similar fold reductions in susceptibility to drug-resistant viruses in both the single-cycle Phenasense assay and the Gilead Sciences multi-cycle assay. The only differences between TAF and TFE were observed in virus breakthrough assays using resistant viruses. Breakthrough occurred more slowly with TAF than with TFE. TFE was used in these assays because it is more stable than TDF in vitro. However, to date, no clinical data are available showing that TAF is more effective than TDF in treating persons with resistant viruses. A discussion of NRTIs would not be complete without discussing the effect of drug resistance mutations on virological fitness and of the clinical significance of the most common NRTI resistance mutations, M184V and I. There have been two main papers that have looked at what happens to mutations in persons infected with a virus containing a drug resistance mutation who do not go immediately onto antiretroviral therapy. The figure on the left shows that M184VI mutations are no longer detectable in plasma in about 50% of patients sometime between 6 and 12 months after infection. The rate of decline is much quicker than the rate of decline of mutations associated with other drug classes shown here. The table on the right is from a different study, but shows very similar rates at which transmitted drug resistance mutations are outcompeted by wild-type revertants. M184VI are no longer detected by 1 year in 50% of the patients. Among the thymidine analog mutations, the two with the greatest effects on susceptibility, T215F and Y, also have a similar short half-life, while several other TAMs usually persist for years. Finally, a third study from the US CDC that created a transmission network from newly diagnosed patients found that viruses with the most impactful drug resistance mutations, T215FY, M184V, and K65R, were rarely found to cluster with one another, suggesting that if they had been transmitted, they faded rapidly over time. There have been more studies about the clinical significance of M184VI than of any other drug resistance mutation. On this and the next slide, I will present 3 studies indicating that viruses with M184VI retain some degree of virological activity in persons receiving 3TC and FTC. The figure on the left is from a clinical trial published in 1995 that shows the mean changes in HIV-1 RNA levels from patients receiving AZT monotherapy, 3TC monotherapy, and AZT-3TC combination therapy. In this study, 3TC monotherapy led to a greater than 1 log virological response by week 2. However, virus levels rapidly rebounded coincident with the development of M184V and I. Nonetheless, virus levels remained about 1/2 log lower than their baseline level for 1 year. 2 other smaller clinical trials that I'm not showing demonstrated very similar results, a sustained 1/2 log reduction in virus load associated with 3TC monotherapy. It is suspected that the residual activity of 3TC against viruses with M184V reflects the reduced replication capacity of viruses with this mutation. The figure on the right is from the more recent E184 open-label pilot trial that randomized patients receiving 3TC containing antiretroviral therapy and harboring the M184V mutation to monotherapy with 3TC, 300 milligrams once daily, or to the discontinuation of all antiretroviral drugs. This study and at least one other similarly designed study were coincident with the four aforementioned 3TC monotherapy trials, showing that the use of 3TC in persons with viruses harboring M184V was also associated with an approximately 0.5 log sustained reduction in virus load. A third clinical trial, which demonstrated the benefit of 3TC despite the presence of M184V, was the Moby-Dip study. The study population included individuals in sub-Saharan Africa who were virologically suppressed for 6 or more months on a second-line regimen containing either boosted lopinavir or boosted darunavir. Greater than 97% of patients had a history of M184VI following their virological failure on a previous first-line NRTI and NRTI containing regimen. The patients were randomized to receive their boosted PI alone, lopinavir or darunavir, or their boosted PI plus 3TC, even though nearly all patients had a history of M184VI. By week 48, there were 30 patients with virological failure in the monotherapy group, but only 4 in the dual therapy group, a finding that was highly statistically significant. In this presentation, I summarized 3 types of evidence that inform what we know about the biological and clinical significance of NRTI drug resistance mutations. We used these data to inform the Stanford Genotypic Resistance Test Interpretation Program. On the following slides, I will summarize online resources that we provide for this program. The data that I reviewed in this presentation are summarized to a large extent in the notes section of the HIV Genotypic Resistance Test Interpretation Program and in a very brief format in a PDF handout. The HIVDB website also contains a list of all mutation penalty scores, which were last updated March 2024. There are individual mutation penalty scores for nearly all drug resistance mutations and several penalties that go into effect only when certain drug resistance mutation combinations are present. The total mutation penalty score for a drug is based on adding all of the individual and combination mutation penalty scores. All drug resistance mutations that receive a mutation penalty score and some mutations that don't are accompanied by a comment. The complete list of comments for each drug class can be viewed on the website. The comments have last been updated March 2024. There is also a table that lists pre-computed scores for all combinations of drug resistance mutations present in the database. The table can be sorted by the number of sequences so that the most common drug resistance mutation patterns are shown at the top, or by those drug resistance mutations associated with the highest scores for an NRTI. It is very useful for us to check this table to make sure that updates to the mutation penalty scores lead to the results intended for actual virus isolates. Thank you for your attention, and if you have any questions or suggestions, don't hesitate to email us.